ladies and gentlemen, welcome to the Cameroon Town Hall for Healthcare Professionals. And I'm presently in the hospital. I'm on call, but it's wonderful to always be with you guys. Today is the 114th episode of the Cameroon Town Hall. So we've been doing this for more than 3 years, and we really do appreciate everyone who is able to attend the sessions. And today is actually one of those special sessions that we have once a year, and we get to talk about HIV. So today we'll be talking about updates on HIV, prevention, treatment, and vaccination. No one better to talk to us about this than Professor Boghuma Titanji. She's been a partner and also a supporter of the town hall and all the educational ideas we've been doing for the past 3 to 4 years. So we just want to thank her. For those of you who do not know her, she's very humble and does not want me to always introduce her, but I'll do a brief. She's a professor of medicine presently. She is an associate professor at the Department of Medicine at Emory. That's one of the most prestigious universities in the US. And actually, when it comes to infectious disease, it's actually the place where you want to be. So we're happy to have her with us. She studied back in Cameroon, so she knows more about the local content. And she has a wide experience from studying in London, has a PhD. She's an MD. She's also an internist and an infectious disease doctor. So we're really glad to have you in the house. Today, I'll be moderating alone. I think Elvis joined us, but he's in the airport. And if he can say a word or two, that'll be nice, Elvis. Are you able to talk?
Yes, Mono, thank you very much. And it's always a pleasure to have Professor Boghuma with us. I'm actually at Heathrow Airport for London, coming back to the US, so I will not be able to speak more, but I'll follow the session. You know, when it comes to Boghuma, it's not a session one will want to afford to miss.
Okay, thank you. And let me make Boghuma co-host and then pass over the mic. So I think also we do want to acknowledge that going forward, we will be having most likely monthly sessions. That's going to be a change for the year. So over to you, Boghuma. You're muted.
Let me just share my screen here with you all. Okay, can everybody see my screen?
Yes, we can see your screen, and I hear you 100%.
Okay, yes. So thanks again for the opportunity to join you all on the Cameroon Town Hall. And today I'm hoping that it will be sort of more a discussion forum as opposed to me giving a very lengthy lecture. And what I'm hoping to do with the slides is to just really set the stage for that discussion. And I think that this particular session is built around the recent World AIDS Day celebrations, or commemorations, which happened December 1st. So I will try to provide you with some updates on prevention and treatment, and also touch a little bit on where we stand where vaccines are concerned. And we all know that World AIDS Day was December 1st. We're doing our own commemoration and discussion about HIV a little bit later. And it's important to just highlight that the theme for this year's World AIDS Day was Take the Rights Path, with a focus really on human rights at the center of being able to end and control the HIV epidemic. So this is the outline of the talk. I'm going to spend some time talking about the state of the global HIV pandemic. And because every year when we're given the updates on the epidemiology, it's for the previous year so that they have a full data set. So the state of the pandemic actually reflects numbers from 2023. Then I will provide updates on pre-exposure prophylaxis and some of the new treatments and interventions that are coming through down the pike, which have been the most exciting changes in the field of HIV this year, and then spend a little bit of time talking about treatment and vaccines, and then really open it up to discussion to think about the future outlook of the HIV epidemic, not only from the global context, but really wanting people to weigh in about the local context in Cameroon, and importantly, in the African continent, which still is home to 70% of people globally living with HIV. So as I mentioned before, the theme for this year's World AIDS Day was Take the Right Path towards ending HIV. And I think that that theme was really meant to focus on the fact that we can end HIV as an epidemic, but to get to that point, it would really require that everyone's rights are protected. And when we talk about rights in healthcare, it's important to emphasize that it's not just the rights of someone who may be wrongly imprisoned, or the rights of someone who may be disenfranchised by virtue of what group they come from, but the right to access to healthcare, the right to making sure that everybody who has HIV is able to get access to HIV care. Everybody who is at risk for acquiring HIV is able to access prevention modalities to prevent them from getting HIV. And that people who may belong to key groups that are more vulnerable, for example, people who work in commercial sex, people who are imprisoned, people who are from migrant communities, or children, that those individuals, their rights should be centered in thinking about the agenda to end the HIV epidemic. Because if you don't focus on the key groups that are most impacted, and you don't focus on making sure that the tools that we have can actually benefit everyone, then we are not going to be able to reach the goal of ending HIV as a global epidemic by 2030. So this is possible, but it would take centering the issue of rights and also letting communities that are most impacted by HIV take the lead in really setting the agenda on how to address the problem. So where does the global state of HIV and the epidemic stand in 2024? We know that in 2023, there were about 39.9 million people globally living with HIV, and that we still had 1.3 million new infections recorded with new infections from HIV last year. Also, tragically, we are still losing way too many people from HIV, with an estimated 630,000 people dying from AIDS-related illnesses in 2023. There are currently about 30.7 million people of that 39.9 million who are accessing antiretroviral therapy. And we know that since the beginning of the epidemic in 1981, it's now been 43 years since that epidemic was recognized and HIV was identified as the cause of AIDS. There have been 88.4 million people who have become infected with HIV over that time. And 42.3 million people have actually died from HIV. So looking at the graphs to your right, you can actually see the epidemic curve in terms of new HIV infections tracking from 1990 all the way to 2023. And you can see that the peak really was around the mid-90s. And since then, we have seen a consistent trend in declining numbers of new infections over time. The little red dot shows you where the target is in terms of what they're hoping to achieve in 2025. And that is a target of 350,000 infections globally by 2025. So you can see that at 1.3 million infections, new infections in 2023, we are still we are almost fivefold higher than the target that we are hoping to achieve by 2025. So a lot of work to do if you think that we barely have 12 months before we get to that point to deliver on that target. Additionally, when we think about HIV deaths from HIV, we have seen a sharp decline in HIV deaths. Again, on this graph below, you can see those numbers track with the tracking from 1990, a peak of deaths in the early 2000s. And then over the past 2 decades, really, the number of deaths has progressively continued to decline, but we kind of had hit a plateau in the last 2 to 3 years. And again, very similarly to new infections, from the global perspective, we're still well above the targets that we aim to achieve by 2025. Now, really focusing back our attention on new infections, it's important to note, like, as I pointed out, that the new infections are continuing to reduce since 1995. And when you compare the graph over time, there's actually been a 60% reduction from the peak of new infections in 1995, which was the worst year in terms of new infections for HIV. In 2023, as I mentioned, there were 1.3 million newly infected people, but when you compare it to the numbers in 1995, that was 3.3 million. So there's certainly been a lot of progress. Unfortunately, women and girls continue to account for a significant proportion of these new infections, 44% of these, and most of these infections in women and girls are happening in countries in sub-Saharan Africa. Now, since 2010, new infections have declined by 39% from 2.1 million to 1.3 million in 2023. And you can see on the graph to your right, again, trying to capture the number of people who are receiving antiretroviral therapy over the period from 2010 to 2023. So you can see that progressively, we've continued to increase the numbers of people who access antiretroviral therapy. But when you see where the target is in terms of where we want to be in our coverage of antiretroviral therapy, we're still falling quite short of reaching those numbers. And so there's also a huge gap that we need to close to get to that target set for 2025. Turning our attention back to the state of the epidemic in terms of deaths, this just shows you on this graph the percentage change in annual numbers of deaths from AIDS between 2010 to 2023. And you can see that consistently, both globally and across regions around the world, we've actually seen a lot of progress in terms of how many people are dying from AIDS-related causes, with every region showing a consistent decrease, except for Eastern Europe and Central Asia, that unfortunately has seen a 34% increase in numbers of AIDS-related deaths. Even the African continent, particularly when you think about Western and Central Africa, there's been a 5% reduction in HIV-related deaths. And in Eastern and Southern Africa, there's been a 57% reduction in HIV-related deaths, which is great, kind of in approaching us towards getting people on treatment and stopping people from dying from HIV-related causes. Still important to note that although we've had all of this progress, in 2023, 630,000 people globally still died from AIDS-related illnesses. And the target that we're hoping to achieve by 2025 is reducing those deaths by at least a third, all the way down to 250,000 deaths. Now, AIDS-related mortality has decreased by 56% among women and girls, and about 47% among men and boys since 2010. But I think that, it's still shocking to imagine that in 2023, with the resources that we have, it's still estimated that someone died of HIV or someone dies of HIV globally every minute. Now, really trying to draw your attention to who is currently most impacted and affected by the HIV epidemic. The thing is, as we have seen a widespread use of antiretroviral therapies and people being able to get on treatment, recover their health, the epidemic has now really focused or concentrated in what we call key groups. So these are key groups or key vulnerable groups of individuals who may have higher risk for acquiring HIV and being a little bit more exposed to HIV than other groups. So the median prevalence globally, when you think about the adult population, the median prevalence for HIV in adults between the ages of 15 to 49 is estimated to be at 0.8%, which is actually quite low. But when you focus your attention on some of these key groups, you would see that it is higher among young women and girls, particularly those in Eastern and Southern Africa, with that prevalence standing at 2.3%. It remains consistently higher among gay men and other men who have sex with men, with that prevalence being at 7.7%. And other overly represented groups include commercial sex, people who do commercial sex work, people who inject drugs, transgender persons, and also individuals who are incarcerated. And I think that the important message when you think about key groups that are still having a high prevalence of HIV is you have to think about this as a missed opportunity. These are groups that if we focus prevention efforts to target or to prioritize, then we can really put a dent in the number of new infections. And on the graph to your right, what you're seeing here is per region, the red dot represents what the 2025 target is for PrEP coverage. So who is accessing pre-exposure prophylaxis to prevent them from acquiring HIV, or who should be accessing it? What is the target? And the green bar shows the number of people who actually received PrEP in those regions. And you can see that across the regions globally, there's a huge gap between populations that stand to benefit from PrEP and who should be targeted with pre-exposure prophylaxis and the actual numbers of people who are accessing pre-exposure prophylaxis to reduce their chances of acquiring HIV, showing a really marked gap that we need to breach if we are to reduce the prevalence of HIV among these key groups that I've highlighted on the slide. And I wanted to sort of end the conversation on the HIV epidemic by bringing back the focus to young women and girls in Africa. Globally, 44% of the new infections, as I mentioned before, were among women and girls of all ages in 2023. And when you hone down to sub-Saharan Africa, those infections represented 62% of all new infections globally. In all other regions, over 73% of new infections in 2023 happened in men and boys. So you can really see how on the African continent, women and young girls are being disproportionately impacted by new HIV infections. And I think it's just absolutely staggering to imagine that every week there are 4,000 adolescent girls and young women between the ages of 15 and 24 who are becoming infected with HIV. And 3,100 of those infections happening per week are happening on the African continent in sub-Saharan African countries. So that's the state of the HIV epidemic, really casting that broad lens to think about the HIV epidemic and where we stand in 2023 from a global landscape. Now, the next part of the talk, I really wanted to focus on some of the key updates around prevention, because I think that currently we do have the tools to effectively interrupt infection with HIV and really drive down new infections. And some of these new prevention tools, we got confirmation of their effectiveness really in studies that were published in the last 6 to 8 months. And I would highlight some of those studies here. The thing that has really transformed the landscape for prevention of HIV has been the introduction or the advent of long-acting injectable agents or drugs that are capable of blocking transmission of HIV. I had given a talk on the town hall before, I think earlier this year or last year around World AIDS Day. And I think that that talk still exists on YouTube. And I would recommend individuals who may not have been on that session to go back and watch that talk, because that talk really gave an overview of the landscape for prevention, for cure strategies, etc. So I had really covered during that previous talk the different interventions that exist to prevent HIV infection. And I mentioned at the time that there were studies that were looking at long-acting injectable drugs to see whether these drugs could be effective in blocking HIV transmission. And two very important studies have since confirmed that the novel drug known as lenacapavir, which is an antiviral drug that targets the HIV capsid, which is an important component of the virus, and is a medication which is, if given through injectable form, is able to block HIV transmission by up to 100%. So the first study that was published earlier this year was published in the New England Journal of Medicine was a study that was conducted in cisgender women living in African countries, primarily recruited from Eastern Africa and Southern African countries. And the question that the investigators were looking to answer was whether lenacapavir, which is the capsid inhibitor that's administered as an injection twice a year, so every 26 weeks, whether it was just as effective or superior to oral pre-exposure prophylaxis such as Truvada or Descovy. So the oral options are once daily pills for pre-exposure prophylaxis, whereas lenacapavir is an intervention that can be given just twice a year. And this was a placebo-controlled randomized study, and they randomized 2,134 women between the ages of 16 to 26 to either receive lenacapavir every 26 weeks or to receive Truvada every day or to receive Descovy every day. So kind of equal numbers of participants between the lenacapavir and the Descovy group, and then a smaller proportion of the study participants received Truvada. And they assessed the incidence of HIV infection in these three groups. And what was fascinating is that they found that lenacapavir administered twice a year offered 100% protection in HIV acquisition in cisgender women in Africa. So you can see on this graph that is shown here capturing the results, the background incidence of new HIV infections, the incidence of new HIV infections in the lenacapavir group, and the incidence in the oral PrEP group. So lenacapavir not only prevented new infections by 100% in this particular study, but was also superior to daily oral PrEP options that have been existent for the past 12 years. Really showing you the importance of having long-acting injectables that improve medication adherence and allow people really to be able to have a preventative modality that can be delivered to them without them having to think about remembering to take a pill every day to reduce their risk of acquiring HIV. Now, there were some local injection site reactions in the individuals who received lenacapavir, but these adverse reactions linked to the injection were really of low grade, just grade 1, grade 2, and very few grade 3 infections. So overall, a really well-tolerated intervention with really, really profound impact on preventing HIV transmission. Now, just earlier this month, I think just last week, a week ago, the same study was replicated this time not in cisgender women, but rather in men and in individuals from gender diverse groups. So particularly individuals who identify as transgender. And in that study, they assessed the same intervention, lenacapavir, administered twice a year, in comparison to the oral PrEP drug Truvada. And they were able to demonstrate that even in this other group of individuals, lenacapavir continued to be superior to oral PrEP in terms of its ability to block transmission of HIV. So only 2 individuals were randomized to receive lenacapavir twice a year, got HIV in the intervention group, and 9 compared to 9 participants in the oral PrEP, daily PrEP group, again showing you that long-acting injectables are more effective at preventing HIV infection, whether you're thinking about their use in men, in women, or in transgender individuals. Now, of course, 2024 has been about lenacapavir for PrEP, but it's important to highlight that lenacapavir is a novel drug for PrEP, and it's long-acting, but it's not the first long-acting intervention that we have for pre-exposure prophylaxis. Before lenacapavir, in 2022, there were actually published studies demonstrating the effectiveness of another long-acting injectable, which is not as long-acting as lenacapavir, but only needs to be administered every other month, so administered every 2 months. So you need 6 injections a year for prevention. And that's cabotegravir, which was shown to be effective in preventing HIV transmission compared to oral daily PrEP in cisgender men and transgender women, but also demonstrated a high level of effectiveness in preventing HIV acquisition in cisgender women in African countries. So we really now have an armamentarium of new interventions that allow people to have injectable options that are very highly effective in preventing HIV acquisition. So just to highlight again some of the benefits of long-acting drugs for pre-exposure prophylaxis, it's improved adherence. The patient doesn't have to think about remembering to take an oral pill to prevent HIV transmission. There's less stigma. You don't have to be answering questions around why you're going to the PrEP clinic to take a medication and taking a particular medication every day, or people judging you that you're promiscuous if you use PrEP, and those sorts of cultural stigma that can be associated with PrEP use. It's convenient, and it's also been shown to be have a good safety and tolerability. Now, the downsides, and I'm sure many of you on this call are wondering, so these drugs are so amazing and so great, how come they're not getting out there so that people can access them? The pricing point currently for lenacapavir is between $41,000 and $42,000 a year for those 2 injections. And for cabotegravir, which is an every other month injection, the pricing point currently stands at $3,700 per injection, which means that if you're giving someone 6 injections a year, you're still averaging about $20,000 a year for someone to be able to be on cabotegravir for PrEP. There's also the need of healthcare professionals to administer it, which will require training to sort of roll out some of these treatments. And there's always the risk that individuals who acquire HIV while on lenacapavir or cabotegravir for PrEP will select for drug resistance for these medications, and you'd not be able to use these medications for their HIV treatment, which they will need. So there's been a lot of talk about and conversation around these drugs were developed and were tested, or the clinical trials were done and largely supported by African countries, with a lot of the studies, particularly studies in cisgender women, happening in Southern and East Africa. Yet, when it comes to the pricing point of these drugs still remain largely out of the reach for a lot of African countries for them to be incorporated into prevention modalities for HIV in our setting. And I recommend that if you're on this call, I really recommend reading this opinion piece that was written in Stat News, highlighting some of those issues in terms of the ethics around drugs that are studied on African populations, but then are not accessible to those very populations that need them once they become licensed. And Gilead and ViiV, the two companies that have developed and brought lenacapavir and cabotegravir respectively to market, were heavily criticized by activists and people in the field about making these drugs accessible, because we do know that they are powerful tools, but these tools are only effective if we can actually get them into the arms of those who need them. So in October of this year, Gilead announced that it will be licensing the production of generic forms of lenacapavir for HIV for use as HIV prophylaxis in 120 low-income countries. Now, they have licensed to 6 companies that are able to manufacture generic drugs. All of these companies are based primarily in Asia, and none of these companies are based on the African continent. So again, I think it misses the opportunity to strengthen R&D towards drug manufacturing and sustainability on the African continent. But at least the pricing point of the generic forms would be at a level that hopefully would be more affordable for these African countries to be able to assess them. Now, it's estimated that to produce lenacapavir, they need just $40 for an injection to be produced. Yet the pricing point of $42,000 shows you the profit margin at which the companies that have developed these drugs are selling the drugs. And it's hoped that the pricing point for some of these generic drugs to start being rolled out in African countries would be closer to that manufacturing cost, which hopefully should be a lot more affordable to African countries. I would, however, highlight that, there's always a difference between the commitment a company makes in order to get generic forms of the medication to the time when you are actually able to start seeing those drugs in clinics and available to clinicians who are serving populations in low-income countries. And I'll take the example of cabotegravir, which ViiV committed to making accessible to populations in Africa at a lower pricing point. It's estimated that it wouldn't be until 2027 that some of these drugs cabotegravir will become widely available in some African countries. Now, this will be 9 years after the first trials to study its effectiveness were started in a lot of these countries. So again, a time lapse between when an intervention is shown to be safe and effective and when it actually trickles down to African countries or lower income countries. The last point is that although Gilead has committed to reducing the cost of the generic of the lenacapavir to make it more accessible to 120 low-income countries, middle-income countries are kind of left out in the dark because they can't access the medication at this lower pricing point. And the higher pricing point of $42,000, $41,000 a year is still too high for a lot of middle-income countries, particularly thinking about countries in Latin America and parts of Asia, which will still not be able to access these medications, yet continue to have a significant burden of the HIV epidemic. So a lot to think about around how we get these interventions into arms. Now, regarding updates on treatment, I just wanted to highlight that by the end of December 2023, according to the latest HIV/AIDS global report, there were 30.7 million people who were accessing antiretroviral therapy globally. And this number is up from 7.7 million in 2010. So we've come a long way in getting people living with HIV on treatment. But the goal and the target for 2025 is actually to reach 34 million people, or reach 80% of the people living with HIV, to make sure that 80% of people with HIV are on treatment. So still a lot of room to hit those targets. In 2023, 77% of all people living with HIV were accessing treatment, so falling short of that 85%, 80% target. And 77% of adults between the age of 15 and older had access to treatment. But in contrast, only 57% of children between the ages of 0 to 14 were actually on antiretroviral therapy. So while we are making progress with better coverage in adults, we are unfortunately leaving children, a lot of these who acquire HIV perinatally, we're leaving them behind, and they're not achieving the same coverage rates as adults where antiretroviral therapy is concerned. In terms of treatment, there's better coverage in adult women at 83% globally compared to men, where only 72% of men age 15 and older are accessing treatment. We are doing better with coverage of pregnant women living with HIV, and 84% of them were able to access antiretroviral therapy, which is important for preventing mother-to-child transmission. I would not dedicate a huge amount of time to speaking about treatment updates, because we know that they're antiretroviral therapies. These drugs work, and that would require a whole session on its own to really delve into what the guidelines currently recommend. But I would urge those who are on this call to please take a look at the antiretroviral drugs treatment and prevention of HIV in adults, latest recommendations from the panel of experts that was just published on December 1st. And that would give you a really good overview and a clear update backed by evidence on what is currently recommended for treatment and prevention of HIV in adults. I did want to highlight just this one important case report that was published in Nature Medicine earlier this year, just documenting the seventh instance of a cure of HIV in an individual who had been living with HIV for 30 years. And this individual is called the Swiss patient. I think that when I gave my talk talking about HIV cure and HIV treatment, I went through different cure strategies that are being looked at to try and see if we can identify a cure that is widely applicable where HIV treatment is concerned. So to date, there have been 7 individuals for whom HIV has been cured. 6 of these individuals have had to receive a human stem cell transplant. So essentially a bone marrow transplant indicated for treatment of cancer. So this latest patient whose cure is documented in this paper is an individual of Swiss origin who had been living with HIV for 30 years, who was diagnosed with a leukemia, a certain form of leukemia, and had to undergo human stem cell transplantation to treat his leukemia. Now, previous instances of cure in individuals who have achieved cure have been from individuals who have had human stem cell transplants from donors that were delta negative for the CCR5 receptor. So the CCR5 is a co-receptor that HIV requires to be able to enter the cell. In the previous instances of cure with a human stem cell transplant, individuals who were cured received a human stem cell transplant from a donor who had a deletion on their CCR5 gene, and as such, their cells did not express CCR5. So when the recipient received a donor from cells donated from this individual, their bone marrow was repopulated with CCR5 negative cells, and the virus could no longer find cells to infect, and that's kind of how they were able to clear the virus and achieve cure. In this latest cure instance, the difference is that they have given the donor in question was not someone who was delta CCR5. This was someone who had wild type CCR5 donor cells. So their cells were expressing the CCR5 co-receptor. And this individual received a human stem cell transplant from this donor after having full body radiation and treatment to condition them for their transplant. And when they engrafted, when their transplant engrafted, they developed a common complication of stem cell transplant known as graft versus host disease. And to treat that graft versus host disease, they were treated with a JAK inhibitor. Now it's been well documented that JAK inhibitors have the ability of reducing the size of the HIV reservoir. And this individual has been maintained on a JAK inhibitor for their graft versus host disease off antiretroviral therapy. And the researchers have done several studies to look for the virus after this person received the stem cell transplant and received JAK inhibitors for their graft versus host disease. And you can see here that they have not been able to detect HIV in these individual cells. And it really indicates that by a combination of both the stem cell transplantation and the immunomodulatory therapies that this individual received for treatment of a complication of stem cell transplantation, the virus has not been able to reestablish itself. And this individual is currently 32 months of antiretroviral therapy and remains in remission from their HIV. It's important to highlight that, of course, human stem cell transplants are not a widely applicable approach to curing 40 million people living globally with HIV because they come with a lot of complications. They're expensive to do, and they also carry comorbidities that are pretty significant compared to the alternative of taking a pill a day and being able to have your HIV fully under control. But these instances of HIV cure certainly give us opportunities to understand ways in which we can intervene on the immune system to hopefully one day arrive at a functional cure for HIV. And by functional cure, I mean being able to control HIV infection off antiretroviral therapy and without needing to be on lifelong therapy for HIV. Now, in terms of vaccine research, there's unfortunately been more disappointing studies where vaccines are concerned, and we still don't have a vaccine that is effective for HIV. I just wanted to point out this and highlight this one study, which was a vaccine trial that was published this year. It's a vaccine trial that was completed last year, but the paper came out this year. And it was a study that aimed to evaluate a 4-dose vaccine that was a vaccine consisting of an adenovirus vectored HIV vaccine presenting multiple HIV antigens and targeted to clade C virus. And they trialed this vaccine in a phase 2B study in Africa, and unfortunately found that the vaccine wasn't effective in preventing HIV acquisition in young women in that particular cohort. So it was one of the latest failures in the attempt to find an effective vaccine. So we continue to try and learn from these failed vaccine studies to find ways in which to improve the development of vaccines for HIV. And accompanying this particular paper was this very important commentary in the Lancet, which I think really gave an overview on the need for novel approaches to thinking about HIV vaccine development. So at the top of the screen, you just see here what is the conventional approach, right? HIV is a virus. It has several proteins. Being able to take some of these antigens, make a vaccine, and then test whether the vaccine is protective in a clinical trial, and then try to understand what the correlates of protection are. So that has been the empirical approach to sort of thinking about HIV vaccines. But in this paper, they make the argument that maybe we need to be thinking about HIV vaccines in a different manner. So actually thinking about ways in which you can induce broadly neutralizing antibody responses to HIV, isolate these neutralizing antibodies once you identify them, and then produce neutralizing antibodies as a way of using that as passive immunization to protect against HIV. So there are currently a lot of vaccine approaches that are looking at neutralizing antibodies kind of as an approach to passive immunization, because so far a lot of the clinical trials and vaccine candidates that have come from the empirical approach have not really yielded the results that we had hoped that they would yield, and we remain without an HIV vaccine until this date. So to close out, I just wanted to sort of frame this and get you thinking about what lies ahead. I think that we can make a compelling argument that we currently have all the tools we need at hand to be able to effectively prevent new HIV infections from occurring. We know that individuals who are infected with HIV and living with HIV, when they are treated and their virus is undetectable and their immune system is reconstituted, they cannot pass on that infection to someone else. So treatment is prevention, essentially. We now have tools that are highly effective to block transmission in individuals who are at high risk for HIV. So I've shown you new data on long-acting injectables, which can now be administered twice a year. And actually, Gilead has announced just 2 days ago that they will be starting a clinical trial in 2027 to evaluate long-acting injectables with lenacapavir administered once a year for pre-exposure prophylaxis. So we have those tools. We have lenacapavir, we have cabotegravir, we have oral PrEP, the daily pill, Truvada, yet people are not accessing them. If we combine treatment as prevention and we make access to pre-exposure prophylaxis widespread, there's no reason why we shouldn't be able to effectively stop new HIV infections from happening. All of the progress that we have been able to achieve over the past 40 plus years of the epidemic are, however, under huge threat. People now view HIV as something that is no longer a public health issue, particularly in countries in the West, like the United States, North America, and in Europe, where it's which don't carry the burden of HIV. 70% of people with HIV live in Africa. So funding is drying up. So while we have these tools, it's also incredibly concerning that, we may not have the funding resources that are needed to actually maintain the gains that we have made over the past 40 years. And we need to continue to see funding in HIV research in order to be able to continue the work that needs to be done to arrive at an effective vaccine and hopefully someday to arrive at a cure that can be widely applicable to people with HIV everywhere. And lastly, the issue of stigma and vulnerable populations still remains a huge concern. It's still heavily stigmatized as a condition to have HIV, and stigma is tied to a lot of those barriers to accessing, be it treatment, testing, or prevention modalities. And it's very important to center human rights, center fighting stigma, to actually be able to properly use the tools that we have at hand to end the HIV epidemic. And with that, I'll stop here and I'll hand it over to the moderator. And hopefully we can have some conversations around some of the themes that I have covered during this talk. Thank you.
Wow, as usual. So this is always a learning opportunity for all of us who do not see HIV, even for those who are seeing HIV. And thank you very much for the wonderful updates. And thank you for your time and for all what you do. I think HIV is a testimony of the brilliance and the things infectious disease doctors have done for us in the past year. So we just want to thank you and all the other researchers for what you do. So we're going to open up the session for discussions, questions and answers, and most likely discussions. Mm-hmm. I would start with, I would start with a few, I don't know if there are questions, just to open up. You did talk about long-acting therapy, which I find this is one of the most amazing things I've heard, which could lead to us actually prophylactically preventing HIV, doing treatment as prevention, the stigma which is associated with those who want to take prophylaxis. Now, back in Cameroon, I'm just asking, where do you see us? How do you see, I know you know the environment in Cameroon, how do you see those who are at risk? Even this, if this becomes available, will they be able to take it? And how long will it be for us to get production scaled up in Africa? Reduction of the cost, you covered some of this, and ensuring that we have distribution in areas that people can safely get these medications without being stigmatized.
Right. I think that you raise very, very important points. And it's particularly for the question of, let me start with, when will these drugs be available and accessible to African countries? I think that it was incredibly welcome to see Gilead, which has never done this before, come to the table and say, yes, we get it, this drug works, and it's unconscionable to not make this accessible to the continent with the heaviest burden of the disease. We're going to get generic manufacturers to make this drug at an affordable pricing point for African countries. And additionally, the PEPFAR program in the US has also committed significant US dollars to be able to purchase and incorporate PrEP with long-acting injectables into PEPFAR programming, some of which covers Cameroon. HIV care in Cameroon is partially funded by PEPFAR, and as has the Global Fund. But a lot of these are in view of being able to become accessible in country end of 2025, 2020, beginning of 2026, mid 2026. So we're still looking at 18 months to 24 months before this becomes something that is a lot more common in the landscape for prevention in African countries. I think some of the countries in Southern and Eastern Africa are likely to access some of these drugs a lot more quickly. I did point out that Gilead played a huge role in coming to the table and making this commitment to generics, but I also highlighted that the companies that they have vetted to make these generics remain companies that are primarily based in Asia, so India and South Korea and other Asian countries. None of the manufacturing is going to happen in the African continent, which is another aspect that has been criticized because it takes away the opportunity to develop capacity for production of these drugs within the African continent where the problem is actually happening. So we will remain reliant on generic manufacturing companies in other parts of the world to be able to make these drugs for us. Now, when these drugs become available, how they are implemented in country, that's where we go back to the question that I brought up at the beginning of this talk in terms of how much of a barrier human rights, access, and high levels of stigma are to actually preventing HIV. Granted, lenacapavir is a fantastic drug. It was shown to be 100% effective in preventing HIV in women in Africa. But let's not forget that we've actually had PrEP options, oral PrEP, which is also over 95% effective at preventing HIV. We've had that available for 12 years. But you can see in terms of the numbers of people who are accessing the treatment that having oral PrEP has not necessarily translated into getting it to those who need it the most. I think that it is possible to get people on PrEP once PrEP becomes available, but that would come through education and removing stigma related to HIV prevention. And I think that in our environment, particularly in Cameroon, it is still heavily, heavily stigmatized. I can totally see how someone going to a PrEP clinic and getting access to Truvada or Descovy, which is a daily PrEP pill, would be viewed as being promiscuous because they're looking to protect their health from HIV acquisition. Whereas if you made it less taboo in a manner in which if you had a PrEP prevention office at every university campus, and it was just part of the care that you gave to university students, and wasn't an issue, people could come in and talk to their health provider and get their PrEP prescriptions, or even get it from a pharmacy, so far as they had a prescription without having to go into a doctor's office, then those would remove some of those barriers. But that has to begin with the Ministry of Health making the deliberate and concerted effort to educate populations about what PrEP is, what it can achieve, and also removing the barriers and stigma that are associated with PrEP access.
Wow. Thank you very much. And you can see we have the tools to end the pandemic. We do. So please, if you have any questions, just raise your hand. While waiting for questions, I will chip in mine. I know you do a lot of research that I know very well concerning JAK2 inhibitors and other JAK inhibitors. I saw this was the first time I've heard about this. I use Jacophay all the time in our transplant patients. Is there any data for the activity of these medications, not in non-transplanted patients, and are there research, or are you planning on running a research in future patients whom we are going to, those who can afford it, maybe see if this was what led to that patient having a cure?
Well, there's a lot of studies on JAK inhibitors and HIV infection, and a lot of that actually happens in the lab in which I work, and they have published extensively on this. It's now been well documented that JAK-STAT inhibitors are capable of preventing HIV infection in long-lived myeloid cells, macrophages, monocytes. That was shown in our lab several years ago by people who predated my presence in that lab. And they also were able to demonstrate in that study that besides being able to block HIV replication in macrophages and monocytes, JAK inhibitors are also able to prevent reseeding of the HIV reservoir. I'm going to go a little bit technical here in terms of talking about the mechanism. How JAK inhibitors are able to impact the HIV reservoir and impact HIV replication is several-fold. The JAK-STAT pathway is very, very important for something we call BCL2 proteins, upregulating, downregulating production of BCL2 proteins. BCL2 proteins are very important. The oncologists on this call would understand what BCL2 proteins are. These are proteins that regulate cellular apoptosis, so cellular death. When you have high levels of BCL2 proteins, cells have more longevity. And BCL2 proteins and increased expression is associated with a lot of cancers. So in the cancer biology field, they usually use BCL2 antagonists, like a drug like venetoclax, to reduce BCL2 expression and reduce longevity of tumor cells. And that's how those drugs work to kill cancer. The JAK activation pathway is able to activate transcription of BCL2 genes. So when you block the JAK-STAT pathway, you downregulate BCL2 and you activate apoptosis, which means that if you give a JAK-STAT inhibitor to someone who has HIV and has a reservoir that is being maintained by long-lived HIV-infected T cells, blocking the JAK-STAT pathway would mean that if you're able to reactivate that reservoir, those long-lived cells can become targeted to die off through the apoptosis pathway. So that is one of the ways in which JAK inhibitors are able to downstream have an impact on BCL2 expression and reduce the size of the viral reservoir. Additionally, they block important cytokines, inflammatory cytokines that are important for T cell activation. To get T cells to become activated, when they're activated, they express more HIV receptors on their surface and are more permissive to infection. So if you block the inflammatory cytokines that are causing activation of T cells and allowing these activated T cells to be infected to build the reservoir and maintain the reservoir, the size of the reservoir shrinks. In this particular individual, they received conditioning therapy for their stem cell transplant, which means that their own bone marrow was wiped out aggressively by radiation therapy and other toxic preconditioning therapies. That in itself would really shrink their HIV reservoir because you're killing off a ton of their T cells. Then you give them the new stem cells at a point where they have a very little virus left in them because you've killed off a bunch of their cells to give them new cells. You are maintaining them on antiretroviral therapy. So even the residual virus that is there cannot really infect the new cells that are replacing the bone marrow. And then they develop a graft versus host disease, and you give them a JAK inhibitor that essentially is acting at shrinking that reservoir even further. So it is the combination and the sequence of events in this particular individual that ultimately led to them being able to essentially eliminate their virus reservoir and not rebound of antiretroviral therapy. Wow. So JAK inhibitors are currently being studied as components of functional cure strategies, not alone, but in combination with other approaches, which I broached in my talk when I went into great detail on how approaches to HIV cure.
Just a follow-up question on that. I know we're getting very technical, maybe, but a follow-up question is, did the graft versus host and the severity of graft versus host, does that affect because I do treat graft versus host all the time. Yes. So did that affect the outcome, do you think?
Absolutely, absolutely did. And in all the other instances of cure that have been documented, all of those individuals have also had graft versus host disease. So the graft versus host disease in itself also contributes to shrinking that reservoir even further. So it's not just the intervention that is targeting the graft versus host disease, but the process of graft versus host disease itself is also another way in which the immune system gets activated in a manner that is detrimental to HIV reestablishing itself. I think that you as an oncologist, you would really enjoy reading that case report in Nature Medicine that really delves into the role of graft versus host disease in this individual controlling their HIV, the role of JAK inhibitors in them controlling their HIV, and the role of the human stem cell transplant in itself.
That will be my reading tonight. So thank you. I don't see any hands up, but I would ask further questions because I think others may benefit. When it comes to HIV vaccination, I know I was sad to see exactly what's happening there. Do we have, I know last time you presented, you told us a lot of strategies concerning messenger RNA vaccine research that is going on. And can you please throw a little bit more light on the broad neutralizing antibodies and how that is being done? And do you think that's the way forward?
That's depending on who you ask as an HIV researcher, some people may think that's the way forward and some people may not. I think that the question of neutralizing antibodies they are an interesting approach to try and use or harness either for HIV prevention or as passive immunization to protect people from HIV. But the real issue with broadly neutralizing antibodies is that we're dealing with a virus that has so many different subtypes and variants because just HIV has a high mutation rate. And we have not yet been able to really crack the code of having 1 or 2 or 3 broadly neutralizing antibodies that would broadly neutralize all the different variants of HIV that are out there. And I think that that's really where the barrier is that while you may be able to identify broadly neutralizing antibodies that neutralize subtype B of the virus of subtype A, there are 100 or other subtypes out there for which you don't have the neutralizing antibodies, which means that it's harder to kind of get a neutralizing antibody that would neutralize every form of the virus. And even in the same manner as the virus is able to mutate and escape the effect of drugs, it's also able to mutate and evolve and escape the effect of a neutralizing antibody. So if you even have a neutralizing antibody cocktail that becomes a passive way of immunizing against HIV, what is to say that you're not ultimately going to apply selective pressure that would lead to viral evolution that ultimately still selects for variants of the virus that are resistant to that particular neutralizing antibody cocktail? So that is really where the issue lies, is that it's very, very difficult the neutralizing antibodies exist, but even the ones that exist, there's no single neutralizing antibody that is capable to broadly neutralize all the existing subtypes of HIV that are in circulation in the world.
Okay, thank you. And Dr. Franklin Maloba, who is a researcher, has broken my stream of questions. So Maloba, over to you, please.
No, Dr. Mone, thank you for the opportunity. You can continue your question after. I just want to go to the global aspect where Dr. Titanji mentioned that women and girls are mostly exposed to the new infection. I wish to find out if some of the reasons for this trend, is it that women expose more of the CCR5 receptors than men? Or is it due to a lifestyle issue? Or what could be some of the factors that is exposing these women at this age or this group than men? Thank you.
Yes, I think that it's multifaceted. It's not really down to just the biology of the virus at all. I think that it's more social factors. It's very well documented that the age group, that 15 to 24-year-old age group of women in Africa that carries the disproportionate burden of HIV, a lot of the times their sexual partners are men that are 10 years and above older than them. For economic reasons, we know, just even if you look in our environments in Cameroon and you look at university students, lots of them are dating men who are in their 40s and their 50s when they're 18, 19, and just fresh out of high school into the university. What that does in terms of the mismatch is that you essentially have a mismatch in the age of the partnered groups, which means that you are matching young women with limited sexual experience with male partners that have more sexual experience and possibly also more opportunities to have acquired HIV over the course of their lives compared to the women that they're partnering with. So a lot of these streams of infections are happening from older men to women. And because there's also that age gap, the power dynamic is also shifted, right? Some of these women are not necessarily empowered to make sure that they are demanding use of barrier protection and having sex only with condoms with these men, because there might be an economic factor. You might have an older man who is paying for your room and who is kind of giving you a certain amount of a certain lifestyle that makes it difficult for these women to actually take some of those precautions that protect them from acquiring HIV. There's also been very well documented the instances of domestic violence from men towards women who attempt to access PrEP services, like be able to get pre-exposure prophylaxis, because there's also the control factor. For example, an older male who is dating a younger woman may think that because she's going to the PrEP clinic to get PrEP and to take PrEP, that means that he's not the only person she's sleeping with, and that she may have multiple sexual partners that allow her to be able to go and get PrEP, and that has led to lots of domestic violence towards women in sub-Saharan Africa. And then kind of coming back to the biology, we do know that the chances of transmission through sex from men to women is a lot higher, just because women have a genital anatomy that is a lot more open than men. And in terms of sexual transmission, we know that penetrative rectal sex is the highest risk. Male to female transmission follows, and then third is female to male transmission that follows. And so women, just by nature of their anatomy, tend to also be a lot more susceptible to vaginal infections from men, compared to, say, a woman who is HIV positive being able to pass that infection on to a male partner who is not HIV positive. And then the final point that I would raise is that there's still also a very high prevalence of untreated sexually transmissible infections, including gonorrhea, chlamydia, bacterial vaginosis, you name them. And all of these sexually transmissible infections, especially those that are associated with a genital ulceration, are risk factors for acquiring HIV, because if you have a sexually transmissible infection that affects the integrity of the vaginal mucosa, then that mucosa becomes a lot more susceptible to an HIV transmission event if you are exposed. So just to kind of give you an overview, those are some of the highlights in terms of the risk factors that make this particular group more susceptible to HIV than others.
Please, just to follow with the biology, specifically the immunology, looking at the CCR5 receptor and the CD4 receptor, which are very important for HIV binding before penetrating into the cell, I wish to find out if there's any study that have actually compared the prevalence of these receptors in male and female to see if that could also be playing a role. Is there any study that has done that?
There are lots of like transmission studies, HIV transmission studies that have focused on looking at founder viruses and looking at vaginal models of infection in macaques, as well as rectal models of infection. It's not down to the receptor expression. It's more down to what types of cells are present in the local environment. Do you have more macrophages? Do you have more T cells? And what the different types of exposure, for example, exposure in the rectal mucosa is quite different from the vaginal mucosa, right? So the cells that are at play in terms of being able to present themselves and have susceptibility to infection can differ based on the interface at which infection is happening. The studies have not shown that there's a difference in cells in receptor and co-receptor expression between men and women. There might be, the differences are more linked to the tissue that is being exposed to the virus compared to it being a factor that is mediated by sex, if that makes sense.
Yes, makes sense. Thank you. Excellent.
Yeah. So please, if there are any questions, just raise your hand and you'll be called up. I know we have just about 15 more minutes to go. I know Professor Boghuma is very busy. I have a question.
Yes.
When it comes to the target for the UNAIDS target of 95 by 2030, we have the tools to achieve it. Do you think this is something which can be achievable?
It is achievable if the funding is put towards it. Like, I think that we've had the tools for a while now. I know, again, that there's a lot of excitement around injectable PrEP, but I keep saying we've had oral PrEP that is 95 to 98% effective for 12 years. And we've not been able to get it to reach 95% coverage in the populations that stand to benefit. So all of this to say that you can have all the tools in the world, even if we had an HIV vaccine tomorrow, if that vaccine is not getting into arms to protect people from HIV, we're still going to be here in a year or in 10 years having a town hall talking about World AIDS Day and the burden of HIV in Africa. There's a significant gap between having the tools and actually having the funding, the political will to be able to make sure that we really use those tools to tamp out HIV. And I worry that as we've gotten antiretroviral therapies and we've gotten to a point where HIV is essentially just a chronic disease like any other disease, you can take one pill a day and live essentially a normal life with the same life expectancy as everyone else, that a lot of the global community has gotten complacent about viewing HIV as a meaningful threat to global public health. And it's getting more and more challenging to convince donors that the fight is not over. And I think that while we stay in that mindset, if we stay in that mindset of the fight is over and we really don't need to be wasting our time investing our dollars in developing better treatments for HIV or implementing the tools that we have developed to fight HIV, then unfortunately, we are not going to be able to meet that target by 2030. Certainly not in the vast majority of African countries that disproportionately carry this burden. There are countries across Europe that have been able to hit those targets, so it's doable. And also countries in Africa that have been able to do it and meet those targets. But meeting a target is one thing. If you meet a target and then PEPFAR funding gets cut, and you no longer have access to antiretroviral therapies for a host of countries in Africa, you can see how quickly those targets will become reversed, right? So all of those gains are good, and we're moving towards where we want to be, but they need to be sustained, and that sustenance has to come from funding.
Wow. There's a question in the chart which is asking what were the criteria that were used by the pharmaceutical companies to select the 120 or the countries that would benefit from this new intervention, and also, do you have any idea?
Oh, in terms of, it's not that they selected 120 countries. They basically licensed generic manufacturing to 6 companies, and the countries that will be eligible to purchase are countries that are low-income countries. Now, there are World Bank metrics based on GDP that would make a country low-income or middle-income or high-income, and they're going to use those parameters. And when you use and apply those parameters, the number of countries that meet those criteria are 120.
Well, one more question. Concerning, I know this should have been a very big advantage for these 6 companies that are selected. Should be, at least one of them should be from Africa. What do you think as Africans? What can we do? We missed the opportunity with COVID. Though South Africa gave us a lot of the different variants, but we missed the opportunities with COVID. Now we're missing the opportunity with HIV, that the burden of the disease is in Africa, in order to develop our pharmaceutical industry.
I think it's a very challenging landscape, right? Because Africa as a continent can clamor for local production, establishment of local pharmaceutical companies to produce medications globally. I mean, to produce medications to serve their own communities. But I think it's important not to forget that even if you have a pharmaceutical company that starts producing antiretroviral drugs in Africa, that company still has to compete with an existing market. That company doesn't, by virtue of being an African country, in an African country, bypass the need to compete with a local, a global landscape of pharmaceutical companies. And it's challenging for a new company to compete because as a new company, one of the things that you'd be looking at, it would be very, very difficult to compete with, say, for instance, the Indian giant that makes a lot of the generics that come into Africa in terms of antiretroviral therapy, to compete with even the pricing point, right? That's the first thing, is that as a new company, there's no way you can compete with the Serum Institute of India that is already has an established production line and distribution line, and the investors that allow them to be able to produce these drugs in quantity, quickly, and readily to distribute to these countries. You are coming in as a small nascent company. Your pricing point would ultimately end up being higher than the pricing point of an Indian company or a Chinese company. So when a government goes to purchase a drug, at the end of the day, they have a fixed budget to be able to cover a treatment for X or Y disease. And they're still going to try and shop around to buy from the companies that are producing at a pricing point that they can afford. So I think that beyond just expecting maybe entrepreneurs who set up drug manufacturing companies, either for vaccines or for medications in Africa, you have to also create an environment in which they can be competitive. And sometimes that would require a commitment from African governments to actually consume locally and be able to trust their local manufacturers and commit to purchasing from them, even if the pricing point is higher. But right now, we're not there yet, which makes it very, very difficult to have companies in Africa that are well established enough to compete with the companies that are already in this space, because we're entering the race at a much later time. And to kind of close out my answer, if you think about the issue of, for instance, vaccines, if I was giving this talk in a room and I could see your hands raised, if you had a child, would you more readily give them a vaccine that had just been produced by a company that was established in Cameroon this year, or would you rather give them a vaccine from the Serum Institute of India that has been producing vaccines for 20 years? Most people would choose the company with a lot more experience, right? Yeah. Just because, again, you're thinking about a biologic and you have to build a certain degree of trust, which only comes with time. I think that African manufacturing has to start small. It cannot be an effort that is country-led only. It has to be regional efforts or continent-wide efforts with a commitment from countries and the African Union to support these industries, to allow them to be competitive with a business landscape that is very, very challenging for nascent companies.
Wow. Thank you. There is one interesting question in the chat. I'll just go with it fast. Long-acting injectable agents, can they be given in pregnant women?
Yeah, some of the women in the study that was done in Africa, the lenacapavir study that was done in South and Eastern Africa, some of the participants became pregnant during the trial, and they did not notice any adverse pregnancy outcomes. So it is safe in pregnancy, but there will be dedicated trials, I'm sure, that will specifically look at pregnant people with more numbers to be able to have us to confidently say that it is safe and safe for broad use in that patient population. But the short and simple answer was yes, in the clinical trial, some women who started the study not being pregnant, became pregnant while they were in the study and still stayed in the study, and their outcomes were no different from the non-pregnant women, and the drug was still safe in that patient population.
Okay, thank you. Dr. Franklin Maloba, your last questions.
Yes, my last question, please. Yeah, this question
is the last question for the whole.
Okay. Yeah, this question is just to clarify the, Dr. Titanji, you know, during the COVID pandemic, the rate at which the vaccine were being produced, a lot of people drew concern, like maybe HIV vaccine was not produced because of maybe the funding people are getting from HIV, things like that. And this has been a lot of issues, thinking that scientists like us, maybe we are not being fair because HIV is mostly in the African population. That's what they say. That's one of my group. So what can you tell this group of people about HIV vaccine?
I am
And
really,
why
really,
is it that we don't yet have a vaccine for HIV
I am
to
really,
that
really
population?
glad that you asked the question. I think that one of the harder things to articulate to the general public is that HIV is a completely different virus from SARS-CoV-2. And what people don't realize is that a lot of the work that was done in looking for the HIV vaccine, in understanding the biology of HIV, is actually foundational work that allowed the stabilization of the spike protein that is used in mRNA vaccines for COVID. A lot of cancer therapy that we have now, CAR T cells, a lot of that research is basic HIV T cell biology that has now gone into cancer biology to be able to answer questions in the cancer field. So 40 years of HIV research has yielded a body of research in biochemistry, in virology, in immunology that has advanced vaccinology and development of vaccines for other pathogens. I mentioned SARS-CoV-2, also the RSV vaccine. A lot of HIV work done on the HIV envelope was used to develop RSV vaccines, and in cancer therapy. The issue why HIV is a challenging virus to vaccinate against is that its envelope protein is heavily covered in sugars, and it is heavily glycosylated. And the domains that are capable of stimulating the immune system in a manner that can generate a protective immune response are very well hidden. It's a very difficult target. That's the first thing. Secondly, HIV has a high mutation rate, so it's changing all the time, which means that even if you find a neutralizing antibody that is able to effectively neutralize one particular variant of the virus, it would not work for other variants of the virus that have a slightly different conformation of that particular target. So I think it's very short-sighted, and that comes from the minds of someone who may be someone in the general public who all they see is COVID came in and we got a vaccine in a year, but we've had HIV for 40 years and we've not had a vaccine. What they don't see is that the only reason we're able to make a vaccine for SARS-CoV-2, which is an mRNA virus, which is a very different target compared to HIV, is because we already had 4 decades of knowledge in trying to find an HIV vaccine, which has allowed us to leverage that knowledge to find vaccines for other pathogens. HIV is just a difficult target. That's the short and simple reason. It's a difficult virus for which to make vaccines. It's not some large conspiracy theory about us researchers not focusing efforts enough. But we have been working hard at it. We'll keep working hard at it. And we've made so many discoveries that are serving other areas of science and health from studying HIV.
Wow, thank you very much.
Thank you.
Professor Boghuma Titanji, and thank you for coming and sharing knowledge with us. We've learned a lot. I have learned a lot about long-acting therapy as usual, updated myself. I wish every physician back home in Cameroon and even here in the US and in Europe could attend this, learn about what we are doing in the field of vaccination. And also really what fascinated me was the discussion about equity and access, and also about ending the pandemic. And the take-home message is that we have the tools. This becomes difficult when you're dealing with a disease where we have the tools. And now we have issues of social and psychological and sociological issues preventing us from really using them well. So would like to get your closing remarks, and we always are ready to have you in the town hall anytime. You're a blessing to the Cameroonian nation, and I hope our country uses you better.
Yeah, thanks so much. And it's always my pleasure always to come to the town hall, exchange with you all, share knowledge, acquire knowledge, and have time to think about our country, our continent, and ways in which we can continue to move health forward. I think that the message I would like to leave with everyone that took time out of their evening to join us today is that, you know, if you don't know your HIV status, you should make sure you get tested. If people around you don't know their HIV status, make sure that you encourage them to get tested. I think that it's important for every one of us that is present on this call to continue the work of speaking up against HIV stigma, because I think particularly in our environment, it's still so stigmatized that it's even very difficult for people to be accepting and open to interventions like pre-exposure prophylaxis. A lot of the work that has to be done in making these interventions acceptable is through us as healthcare professionals, us as professionals in the public health space, who have to continue to educate the general public about the fact that HIV is not a death sentence, it has a treatment, and we now have highly effective preventative modalities, and that there should be no shame associated with someone actively being proactive to seek a way of preventing or protecting themselves from acquiring HIV. I think that there's been a lot of progress made in the last 40 years. There's a long way to go in terms of being able to meet those targets and to be able to achieve what we need to achieve in ending the HIV epidemic. I think every one of us in healthcare has a role to play. And so all I can say is go forth, fight stigma, and let's remove the barriers that are holding us back from being able to effectively put an end to HIV as an epidemic in Cameroon and globally. Thank you.
Wow, thank you very much, and thank you for having time to come over and do us this wonderful presentation. I think we'll be having our next speaker we'll communicate in the next 2 weeks, but next year we're moving over to once monthly town hall. We'll send communications and wish everyone a happy holiday, happy Merry Christmas and Happy New Year. And no parking lot today, given that I'm the only moderator who is around. All my other moderator colleagues are on the flight. So wish you all the best and bye.
Bye.